Welcome back to my channel. We're here to continue our discussion on causes of upper extremity weakness/numbness, especially as it pertains to the PANCE exam. So let's get into it. Let's start by priming the brain. Here's a list of all the diagnoses we're going to discuss today as possible causes for upper extremity weakness and or numbness. Cervical myelopathy, amyotrophic lateral sclerosis, aka Lou Gehrig's disease, TIA, trans ischemic attack/stroke, multiple sclerosis. The next section includes Guillain-Barré syndrome, botulism, myasthenia gravis, polymyositis, dermatomyositis. And the final group, cervical radiculopathy, the peripheral neuropathies, namely carpal tunnel and cubital tunnel syndrome, thoracic outlet syndrome, rotator cuff tears, and shoulder dislocations. How I divided these up is this first group are conditions I treat as an orthopedic surgeon. As an orthopedic surgeon, someone who is strong as an ox and half as smart, these are rather simple. So usually a single muscle group, a single extremity. When I set out to start this discussion, I planned on just discussing these pathologies. However, I quickly found that no test review could be complete without including these other pathologies. So what are these other pathologies? Well, these are what I call complex. So these involve usually multiple muscle groups. It might involve things other than the upper extremity, so upper extremity symptoms, but also maybe facial symptoms or lower extremity symptoms, etc. The yellow diagnoses are the pathologies that include upper motor neuron findings. So these involve the brain and the spinal cord. First pathology I want to talk about is cervical myelopathy. I encourage you to watch my last video for a lot of the details of this. But if you remember, if this is the spinal cord and this is the gray matter, cervical myelopathy is a condition that occurs when the cervical spinal cord gets compressed. This usually is a result of aging, osteophytes, hypertrophy of the ligaments, disc herniations. So this will be an elderly patient usually. And the symptoms will be coordination issues, clumsiness. Coordination. This might manifest as handwriting changes or dropping things. Balance is an issue with myelopathic patients, and they also will get the upper extremity weakness. On the physical exam, this is a spinal cord lesion, so an upper motor neuron lesion. You'll get the upper motor neuron signs, hyperreflexia, upwards Babinski, specifically a positive Hoffman's for cervical disease. That is when this is a hand, that's the index finger, the middle finger, the ring finger, and the small finger. If you flick this middle finger, the thumb and the index finger will flex. The provocative exam for cervical myelopathy is Lhermitte's sign. So you flex the cervical spine of the patient and they will get shooting symptoms down their spine and into their hands. In the late stages, in severe cases, you will get bowel bladder issues as well. Bowel bladder. One thing you will not get in cervical myelopathy is facial signs. So write this in a slightly different color. No facial symptoms. The treatment for this is going to be our health insurance treatment algorithm, which starts with some sort of PT exercise programs. You can include some anti-inflammatories such as NSAIDs. If that doesn't work after a period of time, X-rays and MRIs, and that is the diagnostic imaging that you need, at which point you refer to a spine surgeon. Let's move on to our second diagnosis, ALS or Lou Gehrig's disease. Again, on my last video, I described what this is. This is a spinal cord lesion. This is the gray matter, and it is involving the anterior horn cells of the spinal cord here. sort of where the spinal cord will meet these nerve roots here. Now remember, Lou Gehrig was a baseball player, and he presented with the typical findings of extremity weakness, so weakness of the extremity. He couldn't throw the ball as far. He also had coordination issues. And with ALS, you will get involvement of any voluntary muscle. And that includes the facial muscle. So you can get dysarthria, dysphagia with ALS. What generally is preserved in ALS is your autonomic functions. So no sexual dysfunction, and generally no bowel or bladder dysfunction. The physical exam for ALS is probably the most important part of this disease process. You will have both upper motor neuron signs, so you will have both upper motor neuron signs and lower motor neuron signs. So they will have both in some muscle groups, hyperreflexia, increased tone, and in other muscle groups they might have fasciculations and atrophy. The treatment for this, unfortunately, there is no cure for ALS. Riluzole may increase life by a few months, but generally this is a terminal disease. Now, these two disease processes do have a lot of things in common. They both have upper motor neuron findings. They both have coordination issues. If you're down to these two answer choices on a test, one thing that will help you is that one of these has neck findings and one of these have facial findings. So which one has the facial findings, dysarthria, dysphagia, and which one has the neck pain, neck stiffness findings? Well, obviously the cervical myelopathy patients will have Lahr-Meets sign that will have the neck tenderness, neck pain, and the ALS patient, if they have dysarthria, dysphagia, it's probably not going to be cervical myelopathy. Our next pathology is trans-ischemic attack/stroke. Now the test stem will be some elderly patient, possibly a history of hypertension and or smoking, and they will have sudden onset of upper extremity weakness and probably facial weakness. What this is representing is an ischemic stroke, which is the more common of the two strokes, ischemic and hemorrhagic strokes, and specifically a patient with unilateral upper extremity weakness and facial weakness will be representing the most common of the ischemic strokes, which is middle cerebral artery stroke. And you will get the contralateral hemiparesis of the arm and the face, and sometimes the lower extremity. So weakness, dysarthria, and what's a key finding is the demographics of this lesion. So what is really going to be key is the demographics. On a PANCE exam and most standardized test exams, young healthy people do not get strokes. So they will have to give risk factors for a stroke. The most important of which is hypertension, but other important ones to look for are smoking, diabetes, cholesterol, and of course family history of strokes. The physical exam, again, what is this? This is a lesion of the brain, so this is an upper motor neuron finding. You will get hyperreflexia, upward Babinski. The diagnostic process for this on the PANCE is first you get a CT scan, because that will rule out a hemorrhagic stroke. A hemorrhagic stroke is treated much differently than a ischemic stroke. And if it is an ischemic stroke, then you will start some sort of anticoagulation. And if they're not a candidate for that, some sort of antiplatelet. I'm not going to get into the details of that. That will be for a later lecture. Once again, you have some overlap in these two presentations. ALS and TIA could be easily confused. They both have weakness, unilateral weakness. They both can have dysarthria and dysphagia. So what's the main differentiating factor between ALS and TIA stroke? Well, that will be onset. So the onset between these two pathologies are very different. In a TIA stroke, look for sudden onset. This is a sudden, significant event, whereas ALS is a neurodegenerative problem, so this will be rather insidious. So Lou Gehrig didn't suddenly have weakness. He sort of noticed this gradual increasing in weakness and coordination issues. Our fourth diagnosis in this group is multiple sclerosis. Multiple sclerosis. Now, I had to make a mnemonic for this because this is not something I see regularly as an orthopedic surgeon. I think of multiple sclerosis as the multiverse. So I am a fan of certain science fiction movies, and one thing these multiverse movies have are these scenarios that differ in both space and in time. So these different multiverses will change in space, so characters will change locations or change their dimensions. They also will change in time. And that is sort of the name of the game when it comes to diagnosing multiple sclerosis. So what is it exactly? Multiple sclerosis is a demyelinating disorder. Demyelination of the central nervous system. So it's a demyelination of the brain. So let's draw a brain. This is sort of my brain. Here's a brainstem and the spinal cord. So the presentation can be very variable. The presentation can be pretty much any neurologic problem involving the central nervous system. Some specific findings you might find in multiple sclerosis, things that can draw your attention to this diagnosis, is bilateral face pain in the trigeminal nerve distribution. So bilateral trigeminal neuralgia. Several things can cause unilateral trigeminal neuralgia, but not many things can cause bilateral trigeminal neuralgia. You can get a condition called transverse myelitis, which is a lesion of the spinal cord that will present a lot like cervical myelopathy. So some spinal cord compression and anything below that gets affected. Another important one is diplopia. Diplopia. So double vision, changes in vision. Very common in multiple sclerosis. Now, any of these things can happen. Like I said, the key is that whatever symptom you have will resolve. So the typical patient in the most common form, which is relapsing remitting multiple sclerosis, is a patient will come in with some neurologic finding, and it spikes and it seems to get better. And on a test question and in real life, they will note that maybe they had a similar one 6 months ago or a year ago. And then maybe in another year, they have another event that spikes. And this event, so this is our time axis going this way. This is our disease axis here. This disease might involve the face, the visual changes. This one might involve the weakness in the upper extremities. This one might involve the lower extremities. But the key is that this will change in space, as in it'll be in different parts of the body, and it will change in time, as in you will get an episode and later on you'll get another episode. And that sort of is what you will be looking for on the exam. One rather interesting finding that I think is worth discussing for this exam is the phenomenon in which this gets worse with heat. So in the heat, this gets worse, and that is called the Uthoff phenomenon. And how that will present on the test is that a patient, say, moves from Alaska down to Florida. So when they move down to Florida, their symptoms all of a sudden flare up, and that is called the Uthoff phenomenon. Another hint that this could be multiple sclerosis. The diagnosis for this pathology is an MRI. If you get an MRI, it will show these lesions that we talked about: lesions in the brain, lesions in the brainstem, lesions in the spinal cord. That is the easiest way to diagnose this. You can also get a lumbar puncture, and it has a very distinct finding on the lumbar puncture. So if you get the cerebral spinal fluid, and what they do is they put it on a sort of piece of gel, then they run electric current through, and you put this sample of cerebral spinal fluid on one end of it, and as the electric current brings these proteins down, they will create a signal if there's a protein there. So in a normal cerebral spinal fluid, there is really no signal. There is no protein, or maybe one single one. But in multiple sclerosis, what is a classic finding is that you will have multiple bands, multiple sort of protein signals. And what we call that, or what the neurologists call that, is oligoclonal bands. So oligo, which means several, clonal just means a genetic entity, and a band, which is this band you find on that CSF analysis. The treatment for this: number one, during the flares, you want to decrease the severity of these flares, so you can give steroids, or the mainstay of treatment. There are some immune modulatory medications which are beyond the scope of the PANCE, and beyond the scope of what I know as an orthopedic surgeon. And also in fulminant cases, you can get a plasma exchange, and that is also a treatment option. So that's the first group of complex causes of upper extremity weakness / numbness. These are the ones that included upper motor neuron findings. On our next video, we'll continue our discussion. I'm Will Kang. I'm an orthopedic surgeon helping you pass the PANCE exam.